something very interesting is that the TAVI that our structural heart therapists were performing had a problem or had some issues with the access, because as the graphs evolved and as the technology evolved, they were treated more and more patients. But all these systems were basically dedicated for TAVI, were dedicated for transfemoral. And when the transfemoral approach was not good, then you need to switch to an alternative access like axillar or even carotid or transcaval, which had much bigger problems in terms of complications. So the conclusion is, if possible, if you go for TAVI repair, you should go for femoral. At the same time, we realize as vascular surgeons that local anesthesia is better for this kind of procedures than the general anesthesia. That is something really strange for our mind, but seems that for TAVI it was safer. And today is 2024, so you don't have 24 French anymore sheets, and all these valves, percutaneous valves, you can use go through smaller sheets, but still access a problem. This is why we started to think more about than the access, think about the whole concept and treat the aorta as an organ. And this is the real value of the aortic team. And then you are also securing the access. You can treat the iliacs, reduce complications, and combine the power of endovascular treatment to boost your results and improve your patients. When the access is the issue, calcification is the issue, you have these two possibilities to work in the access. Our preference is the bulking, is the endarterectomy system with the orbital. This is something what we started to use in the last 3 years, and we are more and more using now for this kind of large ball sheets and all these kind of devices. And then we found that from this cooperation, we can achieve much better results. So I would like to show you the beginning of the process with this kind of patient. This is a female that was prepared for going for a TAVI repair. And when we did the evaluation, we found a heavy calcification, as you can see, which is a very big problem for not only for crossing the device, also for controlling the device. So we started to treat this patient with orbital endarterectomy, focus on the more calcification on the right axis. That was the best one. And then through this access, we were easily able to cross with an eye sleeve device, that is needed to go with the valve. And as you can see here, we are with 14 expandable sheath that goes to 18. And thanks to this technique, we were able to safely implant the valve, the aortic valve, after valvuloplasty. And this is the final result. In this image, you can see how the valve was perfectly placed, and the final check after the procedure, no issues in the iliac. We also checked with IVUS with good performance. So what about if you find something more than stenosis? That's another issue. Here you can see a very big aneurysm, 10 centimeter, that was incidentally found when the patient was studied to perform a TAVI repair. And this is a problem for this kind of patients. So when we found this situation, the 3 points I told you before, we are going to add the fourth one. Repair the aorta if needed. So combining, again, the power of endovascular treatment to boost your results and reduce the impact on your patient. And this is the core of the EVART technique that I would like to show you in this video. This one of the latest cases we treat, patient I presented to you before, 10 centimeters infrarenal aneurysm with a heavily calcified aortic valve. So we started in this particular situation with a long sheath to cross safely the aneurysms and straight the iliacs that were quite tortuous. Here we are crossing the valve with an AL1 catheter, which is the preference for these calcified valves. And after that is changed for the safari wire and perform the valvuloplasty after checking the TAVI device on the fluoro. This is a 20 French sheath, dry seal, 65 centimeter. Then we perform the valvuloplasty, check, and advance the TAVI into position. This is a Medtronic TAVI valve. And here our friends from the aortic team, the interventional cardiologists, are implanting the valve, checking. This particularly valve can be repositioned. In this particular situation was repositioned one time, then check, good position. And after this, the valve is totally released. And this is the final check. After the TAVI has been completed, now the patient has a new valve, and we can go on with the endovascular repair of the AAA. Remember, 10 centimeters AAA. For this particular patient, we used CO2 also, trying to reduce the impact of the combined procedures, reducing the contrast. Then we open the bifurcated graft below the renals, check again the neck, and as usual, deploy the endovascular device to the gate, check everything was good in the renal, then do the cannulation. In this particular case, we use a VS1. This is catheter for some tough cannulation, but it was easy. And balloon molding, proximal. This graft we used in this time was a lumbar medical fixed graft, which need to be ballooned. Then we check the right hypogastric and implant a short extension to secure the iliac landing on the right. You can see the deployment of the limb. And then after molding, we also mold the whole limb extension. Then we continue with the contralateral limb extension in a second, check, and also implantation of the contra limb. Was a little bit tortuous, but this is our preference for tortuous iliacs and angulated necks. This graft for us is been working very good for many, many years. So here we are deploying the contra limb and again molding the limb, and the final run with the graft in place, no endoleaks, and good performance. So this is our aortic integral treatment concept, and our experience in the last 2 years, 2.5 years with this model. We evaluated through a 30-month period more than 600 patients. That is all the TAVI repair that are performed in our center, all the EVAR on TEVAR procedures that were performed in our center. From the total group, 83 patients were qualified as complete access or secondary interventions like the EVAR plus TAVI. And from all these patients, just one patient had a complication in the access. And we had finally a mortality in the whole series of 5 patients, which is 0.1% of the whole series, and is probably a very good mortality in this kind of complex patients. We are now performing a deeper study with comparing with a historical cohort before the process of the combining all the technologies together, and this I probably can show you later on. But the take-home message from the aortic team, and this is something that I found very important to report in the vascular surgery and the vascular art congress, is that pre-procedural CT planning is critical, and multidisciplinary approach is very important for all these procedures. We need to explore the whole vascular route, not only the puncture side, not only the TAVI, not only the heart, not only the aorta, and look for penetrating aortic ulcers, AAA, thrombus, or anything that can put the patient at risk. Always need to assess the calcium burden, measure the minimum lumen diameters, evaluate the tortuosity, and any kind of techniques that we have now in our armamentarium, vessel prep techniques can help to get a better result. Use the power of EVART. Thank you very much.
So let's open the... Hello? Nilo, you still with us?
Yes. Yeah. I can hear you.
I'll start with the questions. Congratulations on your paper. I was surprised about your choice of vessel preparation. We have a robust TAVR program in my hospital, and we do multidisciplinary planning, which, as you mentioned, is a key to do it beforehand rather than being called emergently to the operating room. Going back to the device, we found that, as you mentioned, they're mainly calcified vessels. So why risk the embolization risk versus just loosen the media with IVL?
Yes, we had the two technologies together, and we always evaluate the amount of thrombus and the amount of calcium. So when you have thrombus, then of course we are not going to use endarterectomy. But when the main problem is calcium, calcified iliacs, we found that it's safer to debulk the artery more than only work on the compliance, because sometimes the IVL is not enough if you go to cross with 18 or 20 French sheath. So for a smaller sheath, it's okay. But if you need 20 or 18 French sheath, sometimes the results with IVL are not that good.
Nilo, thank you very much. That's a marvelous presentation. And your mortality is very, very low. Now, these are quite sick patients if they're requiring TAVI, and there's a mortality associated with TAVI alone. And also, when you're doing complex EVAR, there's a mortality associated with that. And both of those mortalities are a lot higher than the one you have presented for the combined procedure. And my question is, how selected are these patients for TAVI? And are you taking the best patients for TAVI and doing these combined procedures, or are you taking all patients?
No, this is something that recently changed in my hospital, because before there was a higher selection of the patients. As you know, the guideline indication changed that make we are a high volume center in terms of TAVI repair. We're doing around 250, almost 300 cases per year of TAVI. And now, as my interventional cardiologist said, it looks like we don't have good patients anymore. So what happened is that the major vascular complications related to the procedure basically were reduced to almost zero. And this came from the integrated approach. And the time took out from the equation major vascular complications from the complication rate, as it's not a complication. We are performing not only, like I show you, we are performing also patch angioplasty, we are performing endoconduits, we are performing also bypass surgery before the TAVI. We are doing a lot of things together that basically eliminate the complication rate to less than 3%. And the mortality rate much less than 1%, which was very good. But if you look deeply in my slide, it was a little bit tricky. So I put the ratio from the total group, not from the combined access group. Okay.
So I think we have another question.
Now, good afternoon, doctor. I have some kind of comment and one question. I work in cardiovascular hospital in which we made the same strategy this year, and I can tell that this is true. If we have the multidisciplinary approach, the complication rate decreased substantially, and also the mortality rate during the TAVI. Now we always qualify the patients to TAVI in the team. I mean, cardiosurgeons or cardiologists always ask us about the access, about the potential risks of the access. And after that, after a few months, because we started I don't know, at the beginning of the year, we see the real improvement in outcomes of the TAVI. And the question is, do you do also another procedures? Because we started to do some kind of hybrid procedures in type A dissection, type A aneurysm, like debranching and TEVAR, for example. Do you do such a things or just TAVI support?
Yeah. This is the presentation was around endovascular, so that means that mostly endovascular. But from the type A dissection world, we also changed the way to treat that. Not doing probably not so much debranching. It's more about frozen elephant trunk. We changed from hemi-arc and all this kind of procedure before to build up the proximal landing zone with Vita Open, basically in my center. This is the choice. So again, the same concept also for that.
Because we came to the conclusion to try to do debranching without elephant trunk technique because of the extracorporeal circulation. We not use it during the branching. So it's some kind of minimally invasiveness. But we made a few, so I cannot tell you if it's better or not. Maybe next year.
No,
the
branching is great. What we changed from the branching aspect that was like something 2 or 3 years ago to the use of the open evita technique without a very large, let's say, step of extracorporeal circulation, mostly using the support of ECMO instead the regular extracorporeal circulation, and also doing a sequential clamping and anastomosis with the open evita. That means that the total extracorporeal time is less than 20 minutes for most of the times, which is very good. And this is I am vascular surgeon, this is from our cardiac surgeons.
Okay, thank you very much.
Thank you.
Thank you so much, Nilo, for this nice presentation. Thank you for having you with us. And let's move to the next speaker, Mr.